Good morning. My name is Andrea Baier. I am the chair of the Monument Health Ethics Committee and the medical director of the Monument Health Palliative Care and Hospice Services. I'm here today to talk to you about resource management and triage protocols during the pandemic, both those that were devised and implemented by our hospital, but also what we did as part of a statewide initiative to overhaul the pandemic preparedness plan of the state as a whole. To begin with, I think it's helpful to define crisis standards of care. And crisis standards of care is defined as a substantial change in usual healthcare operations and the level of care it is possible to deliver, which is made necessary by a pervasive or catastrophic disaster. This change in the level of care delivered is justified by specific circumstances and is formally declared by a state government in recognition that crisis operations will be in effect for a sustained period. The formal declaration that crisis standards of care are in operation enables specific legal and regulatory powers and protections for healthcare providers in the necessary tasks of allocating and using scarce medical resources and implementing alternate care facility operations. Let's look at the different levels of crisis care. Level 1 is the conventional standard of care. This is sort of just at the beginning of a pandemic or an endemic where you're starting to feel a little bit of a pinch, but not really any significant change. This is where we all operate most of the time. In that level, the conventional standards of care are followed. That we might need to call in additional staff, but overall we have enough supplies and equipment that it's not a problem. As the threat of activation of the triage protocol increases, the federal, state, or local government may consider recommending canceling elective surgeries or procedures. If not, the hospital may choose to do that, especially those that require a backup option of hospitalization or ventilator support. Contingency level of care, standard of care level 2. This is where many of us operated during the pandemic. That is where conventional standards of care may be minimally impacted. The scarce resources at the hospital can expand to accommodate the surge above its baseline through internal and external resources. They may need to repurpose physical space to accommodate patients. In level 3, the crisis standard of care is what we all try to avoid, which is where the hospital has implemented altered standards of care as demand for scarce resources, for example, ICU beds and ventilators, exceeds internal and readily available external sources. It may need to activate its triage committee. Hospital staff absenteeism is also another factor at play that may be so severe as to become a limiting factor leading to level 3 crisis standard of care. So what do your hospitals need to do? At level 1, they need to be careful to preserve bed capacity by, again, considering delaying or canceling any elective procedures that would require post-op hospitalization. Preserve oxygen capacity by phasing out all non-acute hyperbaric medicine treatments and assuring that all liquid oxygen tanks are full. And improve patient care capacity by transitioning space in ICUs to accommodate more patients with respiratory failure. And finally, controlling infection by limiting visitation. And for level 2, contingency standard levels of care, again, we're looking at preserving bed capacity by delaying or canceling surgery, delaying or canceling category 2 and 3 elective surgeries unless necessary to facilitate hospital discharge. Improve patient care capacity by implementing altered standards of care regarding nurse-patient ratio, expanding capacity by adding more patients to occupied rooms, doubling up on traditionally single rooms, and institute a supportive and/or palliative care team to provide symptom management, counseling, and care coordination for patients who are at end of life. And then for crisis standard of care level 3, The alternative standard of care is implemented by hospital and community to allocate scarce resources. The triage committee and clinical triage officer may be activated at that time, and most likely would be. Again, preserving bed capacity by limiting surgeries to patients whose clinical condition is only a serious threat to life or limb, or to patients for whom surgery may be needed to facilitate discharge from the hospital. So when the pandemic started, of course, none of us really knew what to expect. There was great concern that we were going to be overrun with patients, we would have no place to put them. And so we kind of began at our own institutional level to come up with a plan of where to begin. So our initial concern when we looked at it was the availabilities of ventilators. That seemed to be where everybody's concern was with, given the degree of respiratory failure that all of these COVID patients have, as well as ICU beds. We quickly realized that the ventilators, in fact, were not going to be a limiting resource, especially with the ones that the state government had given us. So, but we did find that at times dialysis could be stretched, nitric oxide, and more than anything, staffing. Staffing, we found out very quickly, became the most limiting factor. We looked at potential for off-site points of care, tents in the parking lot, National Guard, use of hotel space, and this included the important question of where to place those patients who are triaged to end-of-life care. Oftentimes their families would perhaps not be able to care for them at home. We didn't have room in the hospital if we were going to be at that level of care. And so what would we do with these folks to ensure that they had a peaceful and dignified passing? And so as a measure, we developed 3 distinct teams. One was data collection and assimilation. The second was clinical throughput. And the third was emotional and spiritual support. The data collection team was mostly comprised of medical students and residents and some other medical and support staff. They were responsible for collecting clinically relevant labs and vital sign values. Ultimately, the most important thing that we needed was the SOFA or MSOFA score. And I'll talk a little bit more about what those are in a short while. They would place these scores on a grid to be tracked in real time in a command center that we had set up with a big whiteboard grid. Those numbers needed to be updated periodically every 24 to 72 hours. And on that grid, we also kept a running total of beds and ventilators available in real time. And when we looked at when should we begin this protocol, when should we start tracking these things, we decided that it would be when 70% of our ventilators were in use. Fortunately, we never hit that mark. The clinical throughput team would evaluate the collected data and MSOFA scores, ventilator and bed availability. They would do a quick clinical evaluation of each patient, and if the patient had exclusion criteria, then those people could essentially be triaged into the comfort care hospice pathway with referral to the spiritual and emotional support team. At that point, when we had looked back on previous state pandemic protocols, there were a list of exclusion criteria in place. There were several of them, but they included things such as stage 4 cancer, progressive and eventually fatal neurologic conditions like ALS, dementia, infants born at less than 26 weeks gestation, that sort of thing. And if clinically appropriate for inpatient care, then they would help coordinate with the command center to disposition the patient to the right bed and location. Here's a look at the SOFA score. This is a very lab-based score, and it looks at each of the major organ systems. So from a respiratory standpoint, It looks at the ratio of PaO2 to FiO2. It looks at the platelet count. For liver function, it was the bilirubin. For renal function, the creatinine. And then cardiovascular measures were in terms of hypotension, blood pressure, and inotropic support. And then for the neurologic system, it's the Glasgow Coma Scale. The M-SOFA score is a modified SOFA score, and that uses much less laboratory-driven data. It's recommended for triage during a mass influx of critically ill patients. It's easier to implement in resource-constrained settings. It only uses one laboratory value, which is the creatinine, and they've done studies that show that it predicts mortality as well as the SOFA score does. Here's a look at the SOFA compared with the M-SOFA score. So looking at the respiratory system, instead of requiring a PaO2, they simply looked at the pulse ox. They didn't look at coagulation or platelet scores. Instead of measuring the bilirubin, they scored it on whether or not the patient had scleral icterus or jaundice. The hypotension or vasopressors for the cardiovascular was the same, as was the Glasgow Coma Scale for the neurologic. Again, creatinine was used to measure renal function, but that's the only laboratory value that the M-SOFA requires, and that in many places can be done as a bedside test. This graph shows the correlation between SOFA scores and survival rates, and you can see as the SOFA score goes up, the 28-day mortality rate goes up, and it's found to be a very good predictor of survival. Finally, the emotional support team, they would meet with patients and families and help educate them on the role of the crisis standards of care, explain it all to them, as it can be a very difficult thing for people to understand when they're going through a stressful time. They would provide emotional and spiritual support with regard to end-of-life issues, and they would help coordinate with the hospice and home health team to establish care at home or in another needed location, hotel, nursing home wing. We weren't quite sure what all the possibilities were. We worked together with the pharmacy to try to have comfort packs available, readily available, that families could take home so that they would be able to care for their loved ones at home or in an outpatient setting and address all of their symptomatic needs quickly. Fortunately, we did not have to put any of that into play, and we were able to step back and, together with the state, revamp the previous pandemic protocol. The first protocol that was done several years ago was done with the assumption that it would be an influenza pandemic. And so since it had been so many years since it had been done, sort of the state got together and decided it was time to take a fresh look at it, revamp it, see if it was appropriate for where we are today and if it met broader needs than just an influenza pandemic. It was intended to be implemented when a public health or disaster event overwhelmed the usual health and medical resources, capabilities, and capacities, resulting in the inability of the healthcare system to provide the standard level of care to patients. So we began by setting goals, and they were to unify the South Dakota hospitals and work with a common purpose: to prioritize critical care resources during a public health emergency, to help inform local plans, and to help really clarify and identify state versus hospital roles and responsibilities. Purpose was to provide ethically sound, clinically objective, practical, non-discriminatory, and transparent assessment and triage standards for allocation of limited medical resources in the event of a mass critical care situation, during which the demand for hospital and critical care services exceeds capacity. When is it activated? They should be activated medical legally when it is declared by the governor. When the governor states that a pandemic, respiratory crisis, or other public health emergency has the potential to overwhelm our resources, particularly intensive care resources, and that would be when we were at the level 3 that we talked about, crisis standard of care. During this standard of care that is dictated by the governor, the hospital, in conjunction with its medical staff, will use these standards to allocate scarce resources in a manner that respects the human dignity of each patient and saves as many lives as possible. So part of how we proceeded as a state was to look at other states. They did, for their pandemic protocols, looked at states all across the country. The one that seemed to fit the values and the mission of South Dakota was the Northern Texas version, but we put all of this together and came up with several basic premises. The first is to save as many lives as possible to do the greatest good. This would seem obvious, but it's important when we're looking at these protocols in general. It's easy to get lost in the woods of the details of each step, but at the heart of it, the goal is to do the greatest good. Non-discrimination, to treat everyone with respect, care, and compassion, regardless of disability, regardless of age, race, that sort of thing. To provide reasonable accommodation to the disabled. If a patient comes with their own equipment, say somebody who has a Triage ventilator at home, then we may not reallocate that equipment to another patient who may be in need of a similar piece of equipment. Hospital policies should be in concert with the standards that are established. The standards should only be activated when the prerequisites are met, and that was defined as the governor stating that there's crisis standards of level of care, and we're at the level 3. Applying the standards requires an appropriate assessment, and this includes physician judgment. And in the revamped version, you'll find that physician judgment is very much at the core of a lot of this decision-making and triaging, much more than it was in the original protocol. The original protocol was very, very objective, but not a lot of room for clinical judgment and that type of thing. So that's been replaced with a lot of physician judgment throughout the process. Very important also is talking to the patients and their families, finding out what their values and preferences are, looking at their advance directive, finding out who their powers of attorney are, and making sure that this is somebody who even wants to pursue a more aggressive level of care. Looking at the likelihood of survival of each patient, again, physician judgment, using additional assessment tools as appropriate. They got rid of the exclusion the categorical exclusions that I had talked about earlier, the stage 4 cancer, significant dementia, that sort of thing. We are not to take resource intensity into consideration when starting or implementing the protocol, nor are we to consider our perceived quality of life. So in that patient who, say, has severe dementia or ALS, we may perceive that their quality of life is poor, but that is not something that should be taken into consideration as they are placed in and walked through the protocol process. The triage priority, again, is very much based on medical judgment. The hospital will decide how to apply for appeals and how to evaluate each appeal. and that's a hospital by hospital basis. Application by bedside clinicians. This goes sort of with the triage priority. Again, physician judgment. Application by the clinical triage committee, which is basically the clinical throughput team that we had talked about earlier, although there are recommendations for the members of the clinical triage committee, and I'll get to those in a little bit, as well as the clinical triage officer. That person is usually the chief medical officer or the VPMA of a hospital. It's done under the governor's authority, and they strongly encourage, as the protocol is being worked, that new clinical information that comes up for each patient is evaluated in an ongoing basis to make sure that they remain in the appropriate part of the pathway. For instance, somebody who is receiving aggressive care may have a significant decline and a rapid decline that would indicate their likelihood of survival is slim. And so that person, that new clinical information should be evaluated quickly, and that person then likely placed in the end of life hospice pathway. Again, the concept of physician judgment. Application of the standards is felt to be largely a physician responsibility and includes physician's reasonable medical judgment based on individualized assessment of each patient's treatment preferences and survival likelihood based on the best available, relevant, and objective evidence. And it was really stressed that individualized assessment was really felt to be very important. And then as needed modification and accommodation of these standards and any tools that they might need to support their medical judgment based on each individual patient's clinical circumstances, including any disabilities or chronic conditions that they might have. So triage priority. Patients should be triaged first according to the clinician, triage committee, or triage officer's reasonable medical judgment based upon objective clinical criteria as outlined above about survival to hospital discharge. As part of the triage process, there should be consultation as appropriate across specialties, including critical care, infectious disease, hospitalists, surgeons, palliative care, and anybody else who would be relevant to that particular illness in terms of clinical decision making. If one patient's clinical trajectory is declining more rapidly than the other patient needing the same limited resource, then that resource should be assigned to the person whose clinical decline is not as rapid and therefore has the higher likelihood of survival. And then if both patients presented at the same time, a decision may be made favoring the patient with the more favorable short-term post-hospital survivability, as long as it is not based on any of the factors listed in the non-discrimination premises of the standards, disability, perceived quality of life, and those sorts of things. So as we were discussing these protocols, there was a lot of discussion generated about ethical considerations. There were things that we really needed to stop and pause and think about and talk about. At one point, the concept of potentially first come, first served was brought up. For instance, if two people had the same SOFA score and seemed to have the same likelihood of post-hospital survival, then thought was given to giving the resource to the first person to present. The problem with that is that it created socioeconomic bias. For instance, who is the most likely to present quickly to the emergency department should they become ill? Generally, it's going to be older people, people who are wealthier, who are insured and especially well insured, and often Caucasian patients are going to come to the emergency room. They're going to feel more comfortable, and are going to be less inclined to ride it out at home. Who's going to be the most likely to try to ride it out at home and stay until they're extremely ill? It's going to be folks who are disadvantaged, the younger people who are less wealthy, potentially uninsured, and from lower socioeconomic groups, and those who are minorities. So that bias was a concern to us as we were looking at exercising these protocols. The second question is, when we look at post-hospital survival, what does that mean? What is the length of time? Is it 1 week after they get out of the hospital, a month or year, or up to 3 to 5 years? And there's a surprising amount of variability between the different states. Some are up to 5 years. Others are within months to a year or so. A year seemed to be fairly common, but that was something that we talked about needing to define. Removal of the exclusion criteria was another ethical consideration. When we first looked at the protocols and the exclusion criteria, they seemed for the most part to be pretty reasonable and a good way to quickly sort patients who had a low likelihood of survival. Usually we're going to be looking at about a year, who would have a low likelihood of surviving to a year, and therefore a very efficient use of time. Removal of that exclusion criteria seemed to potentially get away from sort of the concept of a protocol. However, I think that there was also concern about not discriminating against people with disability, and so that's where there was some back and forth discussion in terms of what was most appropriate. The role of children in the triage protocol. Originally, the triage protocol included all ages and stages of life. The revamped version is patients age 14 and up. The next thing that we talked about that was of great concern was how people who live in very rural or reservation patients were able to be worked into this protocol. They're not in any particular hospital's service area. And so how would they enter into the protocol? How would they be considered, especially when many hospitals run divert? They could seemingly be excluded from even entry into the protocol and therefore discriminated against. And finally, just placing the heavy responsibility of triaging with the emphasis on physician judgment, causing significant mental and physical stress to those physicians who really were primarily responsible for allocating resources. One of the basic premises that we talked about was an appeals process. It was felt very important that each hospital have a process for patients or their families to appeal. And not only could patient or the family bring forward an appeal, but also a member of the clinical treatment team. So if a physician felt that a patient was appropriate for further consideration outside of the usual pathway, that's something that they could bring forward as an appeal as well. Those appeals would be looked at by ethics and the clinical triage team and clinical triage officer, and again, each hospital would have their own process for that. So what were the general goals of the pandemic crisis standards? Minimizing serious illness and overall death was, of course, the main one, and minimizing societal disruption. During the crisis standard of care, the hospital, in conjunction with its medical staff, should use these standards to allocate scarce resources in a manner that respects human dignity of each patient and saves as many lives as possible. So there was both an ethical and a clinical framework for these protocols, and it was important to remember that every patient is worth our best effort. Um, and in resource deplete situations, there is a moral and practical need to deploy them where they make the most difference. And again, through the heart of it all, that's really what we needed to keep at the center of our intentions. So who did these standards affect? They apply to the hospital, all healthcare professionals and staff working at the hospital. They applied again to patients aged 14 and over. And as I said before, the initial protocol that was established and the one that we established at our hospital sort of as a contingency included all patients from birth all the way through to death. So it was recommended that each hospital develop a framework, a clinical framework for walking through these protocols. The clinical treatment team, as we talked about before, would evaluate patients and apply the protocol and the standards. The clinical triage officer would be available as a resource and to help look at the appeals as they came in, and that would be typically a CMO or BPMA. The clinical triage committee would also help apply the standards. They would act as consultants and help review the appeals. The ethics committee should be available to monitor and review the application and appeals process. The communication was important between all of these different entities working together to help make this go as smoothly as possible. Of course, the palliative care team to assist with symptom management, counseling, care coordination for patients and their families, particularly, of course, those who were placed into the end-of-life protocol, and peer support, having plenty of expert consultation, emotional support for medical staff, and that sort of thing. So who should make up the clinical triage committee? The clinical triage officer, an intensivist, hospitalist, emergency room physician, palliative care, family physician, pediatrician, typically a nursing supervisor or hospital coordinator, a board member, an ethicist, and a representative from pastoral care. So let's look specifically at the algorithm and how it's put into place from a clinical standpoint. So first, looking at the goal of triage. The goal of triage is to favor the most likely to survive over the least likely. This utilitarian perspective is a common feature of all triage guidelines. All also state that patients should be cared for regardless of income, ethnicity, or social status. And there is also fairly strong consensus that neither a lottery nor a first-come, first-served rule is an acceptable option. And that gets back to all of those ethical considerations that we discussed earlier, and many of those are at the heart of these goals. The principles, the basic triage principles, are to give the lowest priority to admission and or access to intensive care services to patients with the lowest chance of survival with or without treatment, and to patients with the highest chance of survival without treatment. So those folks who are likely to die regardless of what we do, and those who are likely to do well even if they're sent home for outpatient treatment. It was recommended that all hospitals have a significant amount of education for the clinical triage committee and really for all hospital staff. The clinicians, the triage committee, and any ethics committee members should receive training on the standards, including the basic premises, and then ultimately it would be excellent if each hospital could provide bias and non-discrimination training to those folks whenever possible. Here is the specific triage protocol, and I know it's very small, but if you look at the top in the gray box, you have the presenting patient. And so initially, we're looking at a discussion about their goals of care, advance directive, power of attorney, establishment, that sort of thing. If they do not want aggressive treatment, then they would follow the decide not to admit pattern, or if they were clearly not going to survive, again, into the not to admit pathway, end of life, hospice care, and the emotional and spiritual support team. Otherwise, if they were interested in receiving aggressive care, then their MSOPA score would be calculated and they would be prioritized as you see. Those with high MSOPA scores over 11 were felt to have a very low chance of survival, and so therefore not optimal to have resources allocated to them, and they were felt to be appropriate for discharge to home or whatever outpatient setting is appropriate for end-of-life care. Those with intermediate SOFA scores between 1 and 11, those folks were felt to have a decent chance of survival, but would definitely need inpatient care, and so they were brought into the hospital. Patients whose MSOPA score was essentially 0, it was felt that they were likely going to do well regardless, and they could be discharged home with supportive outpatient services. Once somebody was felt to be appropriate for admission, then there were specific ICU assessment criteria that included basically cardiovascular parameters and need for ventilator use. I'll talk about those in a minute. If they were admitted to the ICU, plus or minus ventilatory support, then what we would do is look at their clinical assessment and their MSOPA score every 48 to 72 hours and walk them back through the pathway to see if they're still on the appropriate level and the appropriate path. If they improve very quickly or go downhill and decline very quickly to where it looks like they're not going to survive, then they can be walked through the pathway sooner than that, in 12 or 24 hours, and potentially prioritized to home or for palliative care or for outpatient management. So again, if they meet criteria for admission, then there's an additional set to see if they need ICU care, ventilator support, and then it's a continual sort of circling through the pathway based on MSOPA scores and clinical judgment in terms of whether they are ready to go home, either because they're better or because they are deemed to be unlikely to survive. Here's another look again at the MSOPA score, looking at the different organ systems, respiratory, hepatic, cardiovascular, neurologic, and renal. Again, the Glasgow Coma score, looking at eye response, eye opening, verbal response, whether they're able to make sounds, make words, whether the words make sense, and whether they're oriented. And then motor responses, whether they respond at all to pain, withdraw from pain, and all the way up to obeying commands. These are the ICU and ventilator inclusion criteria that I had talked about a little bit earlier. When you look specifically at ventilatory support, There were a very specific set of clinical criteria, one being refractory hypoxemia with a pulse ox less than 90 on either a non-rebreather mask or FiO2 greater than 85%, respiratory acidosis with a pH less than 7.2, clinical evidence of impending respiratory failure. They just look like they're going to peter out pretty darn soon, or the inability to protect or maintain their airway. The second piece of the ICU admission is hypotension, whether their systolic blood pressure is less than 90, and whether they need inotropic or vasopressor support. Other clinical evidence of shock can also be considered: altered level of consciousness, decreased urine output, or other evidence of end-stage organ failure. Again, those folks need to be reevaluated clinically and with their MSOFA scores every 48 to 72 hours to make sure that we have them in the appropriate arm of the pathway, and whether they need to be walked through it again to make sure that they're not either able to be sent home for end-of-life care as they clinically decline, or moved out of the ICU, or potentially even home as they get better. And that's what I have for today. Thank you very much for your time and listening. We put a lot of work into these protocols and a lot of thoughtfulness, and it's going to be an ongoing thing. And I think we've all learned the importance of just keeping up to date on these things and familiar with them, because we never know when something like this might happen again. And I'm open for any discussion or questions. Thank you.